Okay, I have remote desktoped into a Terra Recon workstation because IHS CT collection, Aquarius, CT course acquisition. So this, when you RDP or remote desktop protocol into your workstation, this is what it's going to look like, and they're all the same. Aquarius, Intuition, Terra Recon. So I use Terra Recon because it is the most flexible. It is the fastest to learn, the fastest to read. I'm going to teach you this week in a generic way. I'm going to use terms that are generic so that you can sit at any workstation and learn. These are the cases that are on your spreadsheet by case number. So those correspond to that column. The patient ID is the classification 1 column, okay? And then the study date is listed. There's some columns you don't need, like accession number. So if you just right-click on it, you can get rid of that, and then all week long, you won't have to look at that. So uncheck that, and now the accession goes away. Blank columns like study ID, you can right-click on it, and it'll make that column go away. What you're going to do is click on a case. Here's case 147. It is focused on learning the algorithm. And then down here are the case series that we're going to practice on. Okay. And then once you manipulate that case, then you check off that box on your Excel spreadsheet and you get credit for it. Okay. On the desktop, if you, on the remote desktop, if you read a case, you open up this correlation folder, and these are folders that are labeled with the same case number. What you do is you just tell yourself, okay, I'm going to read this case. This happens to be a coronary case. What I would do is open up the Microsoft Word file that has the date of study and date of birth. And just first read the indication. 49-year-old male with chest pain with exertion and dyslipidemia, evaluate for epicardial coronary artery disease. Then minimize it. Don't read the rest of the report too early. Go to the viewer, find the case, in this case 181. Okay, read it, and on a piece of paper, write down your findings. Commit, doctors, to what you see and how you are going to report it. If you don't commit first, then there won't be any pain if you get it wrong, and you won't learn. With a little bit of pain of missing, your ego gets hurt, and you will remember. All right, then go back to the report and read what I said. And sometimes, not often, but sometimes I deliberately pick cases where I was wrong because I wanted you'll learn more from my mistakes than you will necessarily from all my great successes over 15 years of diagnostic imaging. So in this case, now you read the report. There's a calcium score, the findings, there's injection fraction. There's a radiologist's read of the lung parenchyma here, and then a final impression. And then usually I was in the habit for many years of making a JPEG of where the finding is. And then you can match your findings to that report. Then in here, I have saved things like their cath reports, their H&Ps. If you're an interventionalist, you want to figure out what kind of wire was used, all that's in here. In here as well, in this case, will be a cath report, cath films, and these are all high definition cath films. You highlight those and open them. Play it in Windows Media Player. None of these cath films are lossy. They're non-compressed, large films. So you won't be able to look at a lesion and say it's hazy unless it's your internet connection. They're all high definition. So you can then correlate with the cath. And then in here as well will be other goodies like an IVUS loop. Okay. This is actually an FFR shot. Zoom out. FFR 0.80, okay? So some of the JPEGs are gonna open like that. If it zooms up like that, you need to go to view, zoom out, FFR 0.95. So FFR shots will be in there as well. In some cases, op reports. So in this way, you know, you can dive into the case as much detail as you want. Sometimes you might just want to look at the report. Sometimes you might just want to, you might want the details. I definitely would look at the cath films, IVUS and FFR, if they're there. There are a few cases that won't have a folder. Okay, they won't have a folder here. In that case, there's not many. You just look at the Excel spreadsheet that has the findings, and because that's all there is. Okay. Now, when you do a case, if you have an issue with it, if you struggle and can't get it right, can't find it, just write that down. And each morning we will, as a group, I'll have you guys call out those cases and we're going to do them. Okay, we're going to do them live. This is that course acquisition video. Great music I picked a long time ago. Let's open up Aquarius Intuition Viewer. So when you first open up this Terra Recon workstation here, Aquarius Intuition. Terra Recon is the company and Aquarius is just the workstation name. You're going to see, we don't even need this status column. You're going to see the patient name here, date, ID, and when you click on a patient, I'm just going to stick with this lady here, 00147. When you click on their name, down here in the bottom is a number of series. Now, what is a series? And it's labeled here, series list. Can you guys see my mouse moving, by the way?
Yes.
Yeah, okay. So here's a series list. Now, each scan will have a number of different series listed. And what is the word? Another word for series is recon or reconstruction. When you click on this, you'll see it. You can click on various series and they're previewed in this little window. Now, you're not going to read it on this little baby window, but that just shows you what would be in there. And all workstations are these days in 2020 will give you a little preview of what's in that scan before you actually have to open it and read it. By the way, I'm going to use terms this week that are generic terms. I'm very careful to use generic terms. So the terms I use are applicable to any workstation you might end up using in the future. So when you click on her, there's a number of series that are listed. And some of those, what I want to point out is that these series all came from the same scan. So this patient got scanned one time on one date, but from that data, we asked the CT technologists as the doctor, you tell them and ask them which ones to produce. And various CT labs and various CT scanners will produce various CT reconstructions. So for example, if I pick one that's very recent, like this, for example, this is the only thing that that particular lab produces, 359 images in a single series. But on 64 slice scanners, which are a little slower than current dual source scanners, they're still diagnostic, but they rotate a little slower. we generally produce more data. So this week, you're going to click on case 00147, and then down here will be a series. Now, the first thing I want to teach you is which series to click on to open and what you will use them for, series in particular. So this week, most of the scans done on 64 slice scanners that are dated 2012 or before, they will have a series that goes from 30 to 50% of the R to R interval. Okay, R to R interval is the gating interval from 0 to 100%, 55 to 90, and those are the largest data sets, 2,900 images, 1,800 images. And if you look over here at the baby window and you click on 30 through 50, it'll list it here. You can click on this arrow and you'll see that's 30 through 50. And this picks up. This is the rest of the data set. They're not spliced together, so you have to hit Control on the keyboard and highlight both together. And these two constitute the coronary portion of the data set. Now, how do I know that? Well, if the percentages of the R to R interval are not listed here, then you can tell because they tend to have the most number of slices, 2,900 images in these two and 1,800 in this. Plus, when you splice them together, you can also tell that the slice thickness, let me make this a little bit bigger. The slice thickness is 0.6 millimeters. Now, 0.6 is big enough, is thin enough to be able to see a coronary. Whereas the other slice thicknesses are not. If you click on the EF, for example, its slice thickness is only 2.5 millimeters. 2.5 millimeters is definitely not big enough to see a coronary, okay? Because a coronary is 5 millimeters across, that's only going to give you two pixels, 2 boxes across a coronary. So you wouldn't use that series to assess the coronaries. Now, I told my protocol in Sentara Heart Hospital was for many years to produce these two series, 30 through 50 and 55 to 90 for the coronary portion, then to produce a large field of view at single phase, 75%, to be used for the great vessels, for the aorta. Okay. And you see the field of view is large. You can see the subcutaneous tissue. You can see the entire lung and thorax, as opposed to this one, where the field of view is coned down. It cuts off the vertebral column. It cuts off part of the lung. And so you use the coned down field of view series to assess the coronaries for the heart. And that is step 1 and 2 in the algorithm. And then you use the 75%, which is the large field of view, for step 3 in the algorithm, which is called thoracic housekeeping. If you look on the 3rd page of the algorithm, see where it says thoracic housekeeping, step 3. When you get to that step, that's where you look here on this series, okay? So that is the methodical way of using these series. Now, at the very end of the algorithm, we'll look at the ejection fraction, and for wall motion abnormalities, that's at the end of step 3, and that's when you use this series called the EF. And the EF series, sometimes it's not labeled EF, but you can tell it should be used for EF because it's thick slices, 2.5 millimeters, and it has all of the phases of the cardiac cycle, 5 through 95% of the R to R interval. Okay. Now, let's pause for a second and let me answer a question that you may already be wondering, which is, what do these percentages of the R to R interval mean? Okay. let's just pause for a second. Okay,
Yeah.
so I put a Wigger's diagram on here. Now, and I just drew a little line. The R to R interval of 0 to 100% of the R to R interval refers to systole and diastole. Okay? Just pay attention right here where I'm rotating for a second. The standard convention is that systole and diastole go from 0 to 100. So systole is from 0 to about 30%. Okay? 0 to 30%, that's systole. And then diastole is 30 through 100. Now, the phases of the cardiac cycle have various utility to us. The heart is still moving faster than the best CT scanners around. Even the dual source and the Siemens Force scanners are still just slower than the heart is moving inside the chest. So as a result, not all of the phases of the cardiac cycle are helpful for us because they don't all freeze cardiac motion for us to be able to see the coronaries very well. So what you got to do is you got to basically memorize which are the phases of the cardiac cycle that are most helpful. So where would you guess the most helpful phases of the cardiac cycle in percentages are? Anybody?
75% a good spot.
Okay, 75% is a great spot because 75% is exactly right here. Diastasis. Okay. So diastasis is typically 60 through 80. 60 through 80. Okay. So if you told me what are the phases that you want the most, Basine, it's 60 through 80% of the R to R interval, right in the middle of diastasis. That's another way of saying that is right the period between the E wave and the A wave. Okay. Okay, between the E wave and A wave. Now, where would you guess the A wave begins? What percent?
90.
90. You got it. Okay, 90. So if you told me, Basine, you could only have one phase, I would pick 75. If you told me I could have a few more, I would pick 60 through 80. Okay? 60 through 80. That's my 6. I'm drawing it with a mouse, guys. Don't make fun of me. 60 through 80. Now, that's why there's a lot of motion in early passive filling from 30 through 60. There's a lot of motion from 90 to 100. So for many years, I told my techs, I want you to just reconstruct 30 through 90, 30 through 90 on everybody. Okay, so on 64 slice scanners, I tell them just reconstruct 30 through 90. That way I get diastasis, 60 through 80 portion with 75%. And there's a little area here of time when the heart is actually frozen as well, and that's late systole. At the end of systole, after the heart has ejected all its blood, it relaxes for a moment, and that's called isovolumic relaxation, and that's right here. So that tends to be at about 35, okay, before the E wave begins. So there's another sweet spot right here, and that's about 35. maybe close to 40. So isovolumic relaxation, sweet spot. 60 through 80, diastasis, sweet spot. So there are two sweet spots, diastasis and isovolumic relaxation, because those are the two areas of the cardiac cycle where the heart is frozen. So if you can get 30%, 35%, perfect. Now on those old 64 slice scanners, in some places you're still using 64 slice scanners, just to make the tech's life easy, we just said, all right, just reconstruct 30 through 90. That way I know my two sweet spots will be incorporated into that data set. And that's why on the Terra Recon here, many of the cases that you're going to see are 30 through 90. Why are they split into two phases? Because this old scanner had a 3,000 slice limit. So that's why you have to splice them together on the workstation by hitting control with your left hand and highlighting them both and then opening them up, okay? So the whiteboard again, key is if you only have one phase, pick 75%, right in the middle of diastasis. If you, and I use that 75% for the great vessels, for the entire chest, for the series of that goes with the thoracic housekeeping step 3 in the algorithm. I use for the coronaries 60 through 80 on a modern dual source scanner, but on 64 slice scanners, I just tell them, give me 30 through 90 because I want this this systolic sweet spot and the diastolic sweet spot on the workstation. Because sometimes the LAD comes in perfect at 60, but the circ will come in perfect at 35. So you have to scroll sometimes through different phases to find different segments. Some various coronary segments are out of phase with each other. Let me show you same thing with the tissue Doppler. Those of you who are echocardiographers have been doing tissue Doppler for many years, systole and diastole. Diastasis is that period between the E wave and the A wave in your tissue Doppler. So that's 60 through 80, right there between the E and A by tissue Doppler. That's where motion is motion free, right? So this is where we're shooting for, 60 through 80. And if you only had one phase, it would be at 75% of the ART-R interval. All I'm teaching you right now is nomenclature. You probably know this by milliseconds of the cardiac cycle, but never thought of it in percentages. But percentages just gives us an accurate way to tell you where we are in time on the Wiggers diagram or the cardiac cycle. Okay? Now, there is a large study of dual source CT scanners, and dual source CT scanners are the fastest scanners around. And it basically shows us that you need a lot of phases of the cardiac cycle if you care about accuracy, or if you don't beta block your patients well. In this study, what they did was they scanned lots of people and they looked at which was the phase of the cardiac cycle that was optimal for the LAD, for the circ, for the RCA. And they also stratified them by whether the cardiologist beta blocked the patient well to a heart rate less than 70, or whether they didn't beta block them well. They allowed their heart rates to be higher at the moment of the exam of the scan to greater than 70. And what you'll see is if you do a good job beta blocking the hell out of your patients and get their heart rate to less than 70, then the majority of patients are going to have their LAD optimal at 70. There might be a few where their LAD is best seen at 60, some at 80, and there might even be one where it's best at 40, but the majority are at 70 or 75. If you don't do a good job beta blocking people and you allow the scan to acquire at a heart rate of 75, 80, then you need more of those other phases of the cardiac cycle to find the optimal phase of the LAD where it's crisp and sharp on the CT. So that means you need more of that isovolumic relaxation period, which is 35, 40% of the R to R interval before the E wave hits, okay, of early past filling. So LAD, CIRC, same thing happens. RCA, same thing happens. So one of the lessons of this is beta block the hell out of your people, okay? So don't run a lab where you're not pouring drugs into people and you shoot for a heart rate less than 70 or even 65 in everybody. So in our hospital, it's not uncommon for me to tell on our protocol to give people 200 of low pressure right away. And then after 30 minutes, give them another 100 of low pressure. And if that doesn't do it, we'll give them up to 40 IV of low pressure. At that point, they're probably, every beta adrenergic receptor is blocked with a molecule of metoprolol. Then we add either Corlinor, 7.5, or we'll add, if they're anxious, we'll give them a touch of Valium, 2.5 of Valium if they have somebody to drive them home, or we will add a little DILT. But I don't like to add DILT because that's when you start to see the blood pressure fall. You don't see hypotension with low pressure. Once you've, you guys know in your own clinic, when you give somebody a bunch of, you don't give beta blockers for hypertension because you're not going to get a lot of benefit out of that, right? So that's where we use, that's where we use a lot of beta blockers to get a good heart rate reduction. So that's what these percentages of the R to R interval stand for. Okay, so we use, to review, we click on the lady that we're going to read. Let's say this is a lady with chest pain. The first thing you want to do is clear the coronaries of any coronary disease. So you're going to highlight the two series labeled 30 through 50 and 55 to 90. The computer will splice those together. On this course, many of them are labeled, the coronaries are labeled 506. That's a meaningless number. It just happens to be that scanner I used at the time for many years labeled them 506. And it labels the ejection fraction part of the data set with a 556. But the better way is to look down at the baby window and see what the slice thickness is and see what are the percentages of the R to R interval. Because if you click on the coronary data set, it's 0.6 millimeter. I don't know if can you guys see that? It says 0.6 or is, yeah? Okay, that's 0.6. So that's thin enough to assess the coronary. But when I click on the ejection fraction, it's 2.5. So that's not thin enough to see a coronary, but it's good enough to calculate an ejection fraction. Okay. Now, when you get to step 3 in the housekeeping, you click on the 75%. That's thin, but it's a large field of view. So let me review. When you sit down at a workstation, any workstation, Terra Recon, Vitria, whatever, when you click on a series, you look at the baby window and you should be able to logically deduce what you're going to use this series for by asking 4 questions. Number 1, is there contrast in the series? And there is contrast here in the great vessels. If there's contrast in it, then it's not a calcium score, okay? If there is no contrast in it, then it's just a calcium score, and the only value to you is going to be to calculate a calcium score, or maybe look for calcification of the pericardium. The second question to ask is, what are the percentages of the R to R interval? Hopefully it's in diastole, okay, between 60 through 80, but if it starts in 30, that's okay. Next question is, what is the slice thickness? If the slice thickness is less than, is 0.6 or smaller, you can use it to assess coronary disease. If it's thicker than that, like 2.5, you can't use it to assess coronary disease. Okay, you got to use that, use that for some other purpose. And typically that's ejection fraction calculation, but you could also use it for, say, something that doesn't need that thin slice. You can use it for finding a wall motion abnormality. You can use it for doing a mechanical valve cine like we're going to do this week. anything that's larger than a coronary, any structure that's larger than a coronary. And so you can play this cine, and while it's playing, it'll take 2 seconds to warm up, and then you can scroll through it and look at the heart, and you can see the heart squeezing. You can speed it up by clicking this little cine loop, and you could find a papillary fibroelastoma. I found vegetations this way. I found, other dingleberries hanging off the tricuspid valve through the years, things like that. Okay. All right. Now, you don't read on this little slice, this little baby window. Let me stop and see if anybody has any questions. We've discussed just the buttonology on this screen, the buttonology here of series, the baby window, gating relative to the cardiac cycle. Here's how you open it. Let's say this lady has chest pain, and I happen to know that she doesn't have any coronary disease. That's why I picked her, so you guys don't start staring at her plaque, wondering how you're going to call it. What we're going to do is click 30 through 50 and 55 through 90 here, because that's the coronary portion of the data set. And then you right-click on it, on both of those together. And what you will see on the right-click menu is a number of presets that are going to open this into a 4-dimensional viewer. And that 4-dimensional viewer is listed here as a 4D. The one that I want you to use, the 3 that I want you to use this week, I have labeled here Centera heart, pulmonary vein, aorta, and calcium score. Now, we should probably relabel them at some point IHS, because they're actually an IHS preset. But I'm giving you these. These presets come in a little file, and I am giving them to you. They're on the IHS CT collection, okay, so that you downloaded. I'll show you where they are while I'm talking about it. Up here on IHS CT collection, this is that 4 GB folder that you downloaded. They're right here. They call Basine, Centera, TerraRecon workflows to import. So if you have a TerraRecon workstation in your home institution, all you have to do is to take these files, and you can import them. And here they are labeled by the name IHS. Perfect. And they will set those presets up in your TerraRecon system, so you don't have to. So whatever workstation you use, if it's a TerraRecon, they'll work for TerraRecon only. Sorry, you will have these presets the same way you've been using them all week. Oh, I hit the wrong button. If you ever hit the wrong button, this is going to happen. It's going to split the screens in 4. And then you got to wait for this green line to come back across. It's my mistake. As soon as the green line comes across and the wheel stops spinning, I'm going to go back to this patient list. Okay. So I loaded it wrong. What you do is you highlight these two and right-click. I want you to go to Centera Heart. So Centera Heart is the presets I've been using for 15 years. There's no reason for you guys to reinvent the wheel and come up with your own presets. And when you click on that, it's going to load the coronaries into a 4-dimensional viewer. Now it takes a minute because it's a large data. It's about 5 GB of data that's loading into the GPU in the cloud. And while this green is there, it's not going to let you do much. All right, now what we're looking at here is called a 4-dimensional workstation. And this is the main TerraRecon software that you're going to use. And this is the buttonology that I'm going to teach you. What you're looking at is a CT data set in 4 dimensions. There's a number of buttons. In fact, there's way too many buttons. Okay, it's one of the busiest. All these manufacturers of software have created very, very busy workstations. And I think one day there's going to be an AI algorithm that's going to basically intelligently say, look, if a doctor hasn't touched any of these extra buttons in 90 days, it should just disappear from the graphical user interface. But for now, we're stuck with the buttons that are listed here, okay? So what I want to do now is go through the buttons you need and I'm not going to touch on any buttons you don't need, okay? Because there's so many different buttons up here. I want to show you the 6 buttons you need on the software to read a cardiac CT. And there's tons, might be a few nifty ones, but there's a ton you don't need. And then I'm going to show you the moves on the mouse. I actually can tilt my camera towards the mouse if I had to, but the mouse moves are the next buttons, and then we'll be done with Buttonology, okay? So you guys can do this, and for the first day, you're going to be a little fat, you know, you're going to be getting some muscle memory with the mouse moves, so it'll take a day to get ready, to get comfortable with the mouse moves and the buttons. But once you do, then you really start flying and absorbing pathology really quick because you're not thinking about the mechanics of how to run the workstation. Up here at the top, the good news is you don't need any of these buttons except for one, and it's this one. It's called distance. The cursor changes on the screen and you can measure something. Okay, and now we've measured the aorta, the PA, and now you right click on it and you go to delete measure and it'll go away. Okay, or if you are looking at the aorta in black and white, you want to measure it here, you can click distance, measure it like this, and you've got now your measurement of the aorta. And then you can right click on it and delete. Tomorrow, we're going to planimeter some aortic valves and do some TAVI. Here's a trileaflet aortic valve. And when we cut underneath, tomorrow we're going to use one other tool on this menu up here, and that's called polygon, where you then planimeter the annulus so you can tell your structuralist what size TAVR. And this is 90% of what they want from a TAVR scan, okay, is what's the valve area so they can put that in a valve sizing chart and its perimeter. Okay. Now, that's it for buttons up there on the left top. Over here, there's a button that will turn on and off annotations. Like if you want to turn off all the annotations and manipulate it without all that noise, you can do that. Or if you want to take a screenshot without any of that stuff, you can do it. There's 3 tabs here. You can go to patient list and it'll take you right back to this list where you just were and go back to viewer. There's an output panel, which you're not going to need this week because you're not actually reporting. But if I was reporting, let's say I wanted to capture this picture, I click this camera button and it basically captures that picture to the Windows clipboard and captures it into the output panel if you want to add that to the report. But since you guys are not actually making reports this week, except on pieces of paper at home, you're not going to need this output panel this week. Okay. Now, other menus. There are a series of menus that go up and down the screen here. So this menu collapses and gets enlarged by clicking this little arrow. This menu collapses and gets enlarged by clicking this little arrow coming up and down the screen. The next most important button is the phase window. So that's these 2 little buttons here below the time. You can move this arrow and it will move through time. 90% of the RR interval, 30%. These are, if you look at the ventricle, these are moving through systole and diastole. 80%. When you get to systole, you see the ventricle is smaller, okay? So these move through time. You can also just drag this red bar back and forth through the the phases of the cardiac cycle. So for the phases of the cardiac cycle, you can also cine. So if you hit this cine button here, it'll play this in a cine mode. And while it is playing, you can also manipulate it. Okay. So you want to see a short axis view. You want to see a 4-chamber view. You want to manipulate it to a 2-chamber view. You can do that. Or a 3-chamber view. While it's cining, can all be done that way on a 4-dimensional workstation. So these are buttons that scroll through the phases and then play the phases. And while it's playing, if you want to change the loop speed, you can change the loop speed. Now notice, if you slow down the loop speed and visually call the EF, you'll call it 30. If you increase the loop speed, you'll call it 55. Okay, so loop speed has everything to do with your visual estimation of ejection fraction. So pay attention to that. The other important buttons you're going to need. Over here are window width and level settings, presets. And down here are also the same presets, more presets for window width and level settings. I'm going to tell you, we'll get to what those are in a second. But those are adjusted by clicking this MIP button automatically. Will it change your presets to 700, 350? So this week during the course, you probably won't have to worry about that if you use these macro buttons I'm going to get to here in a second. Window width and level refers to the fact, it's a terrible name, window width and window level. I want you to just forget these terms because they're so confusing. What a window width and window level actually are the, I want you to replace these terms in your mind with the term range of density values and median value. So window width is the range of density values that are displayed on the screen, and median value that's displayed on the screen. You may remember from radiology, if you were like me, you probably blew off your 2 weeks of radiology in medical school and went to the beach and then had to relearn this later. But what is a CT scanner? What is a CT data set at its most basic level? Here's what a CT scanner is at its most basic level. Let me put this on the screen. A CT scan is this, a matrix of voxels, of cubes. Voxel stands for volume pixel. So a CT scanner a CT scan is nothing more than a matrix, 3-dimensional matrix in an X, Y, and Z plane of cubes, where each cube represents density of tissue. And that's what this matrix is. Okay, it's a matrix of little cubes. Now, if you zoom in, you can see the actual cubes. Okay, there's the cube. And if you put your cursor on any cube, if you are on the most basic viewing algorithm, which is called the multiplanary format, if you put your cursor anywhere on the screen, it is going to tell you what is the density in Hounsfield units at the tip of that cursor. And it's listed right here. HU, Hounsfield unit. And that is, for Hounsfield unit is also called the attenuation coefficient. And that is the density at the tip of the cursor. So for example, if I put my cursor in the myocardium here in the meat, what Hounsfield unit do you get up there?
47.
You see 47. If you put it in the aorta, which is filled with iodinated contrast, and iodine is very dense, we see 356. If you put it in the middle of the lung, you see minus 669. If you put it on the bone, the ribs, bone here on the edge, you get 795. But if you put it in the bone marrow inside the rib, you get 26, which is soft, mushy bone marrow inside the rib. So what is this scale we're talking about of Hounsfield units? Well, Sir Hounsfield came up with a Hounsfield unit scale the year I was born in 1972. He got the Nobel Prize for CT. And the scale he came up with it's called a Hounsfield scale. And on this scale, water is set arbitrarily to 0, and air is set to minus 1,000. Okay, because he reasoned that we are all mostly water, 70% water, and our lungs are filled with air. So it's minus 1,000 for air and 0 for water. So bone falls in the much more than water density area. So 700, 800, and then myocardium, of course, like 100. Iodine is very dense. So when we inject it appropriately and time it to the aorta, we get 300. And we look to see if a scan is a good scan. We look to see that at the tip of that cursor, we're getting 300-400. That means we appropriately time the contrast in the power injector. If I put it into the PA, which doesn't have as much contrast in it, because this is a coronary CT, it has less. And if we put it in the right atrium, it has even less, 92. Okay. Now, what is the window width and level setting? Well, to understand what these settings are, the range and median, I have to remind you that your eyes cannot appreciate all the values of density on a scale of minus 1,000 to plus 1,000. Guys, how many shades of gray do you think your eyes can tell the difference? If I showed you a black and white television, or a screen that's only in black and white, how many different shades of gray do you think your eyes can see? Guess.
15,
Just guess.
15 to 20.
15 to 20, man. Somebody said that? You got glasses on? You doctors put your head down and looked at a book since you were age 18. Yeah, maybe you guys, your eyesight is bad enough at this point. No, you can see more than that. 40 to 50 shades of gray, just like the book, okay? Which I haven't read. Now, years ago, it was felt that in the 1960s, the RAND Corporation studied the eyesight of jet fighter pilots zooming around the desert because they had to look at black and white screens to decide where to fire a missile on a bogey. And it was felt that they could discern 400 shades of gray, and that's a total lie. It's a total lie. We can only tell 40 to 60 shades of gray, black and white. So as a result, we have a problem if we want to create a CT modality that it can calculate the density of several thousand units, but our eyes can only discern 40 at a time. Okay, so how do I display on a CT scanner lots of encoded values for you? There's only one way to do it, and that is to produce on the screen various presets that scroll through that will display various densities on the scale, on the Hounsfield scale. So if you see these numbers changing as I click different presets, or as I move this slider bar, you see that the various densities that are actually shown on the screen will change depending on the preset. And the window width and window level are, in fact, the range of encoded values displayed, the range of density values displayed versus with the median value display numbered here. Okay, so median value displayed on the screen and the range. Now, but the word, what's his name? Hounsfield used the word window width and window level, and as a result, those names stuck. But they're confusing terms because when you think of the word window, you think that it's referring to the image, but it's not. It's referring to a window on the total encoded density values that could be displayed, okay? Now, here's some caveats of the window width and window level settings. Number one, if you click on a lung window, for example, Lung window will show you fissure in the lung. It can show you whether the patient has usual interstitial pneumonitis, COVID pneumonia, ground glass. Also, it'll show you lung findings, but it's not going to give you any differentiation between the aorta and the vertebral column, because both of those densities are outside the chosen window, median and density value. You see the center, the window median value is -700, and the window width is 1500, meaning the range is no more than half that above its level. So there is no dynamic range at a lung window of -700. There's no dynamic range for being able to tell the difference between the vertebral column and the aorta. However, if we change to a different window width and level, let's say a window median or window level of 200, with a range on either side of that 200 of 800, which means 400 above it and 400 below it, then you will see that you can now not tell anything about what's going on in the lung, because those lung density values, while there, are not being displayed. But you can tell the difference between what's aorta and what's vertebral column, because those density values are being displayed at this moment. Make sense? Is it coming back to you from radiology from a long time ago? Okay. This is the part of the training where if you're a radiologist, you're incredibly bored because it's like 101. But if you're a cardiologist, you probably need a little refresher on this. Any questions about window width and window levels? Okay. The part that the corollary of this that is very important for CT readers and cardiologists is that by changing the window width and level settings, I can make a stenosis go from 40% to 80%. So those of you who read Nuclear Donuts, you probably have heard the phrase ischemia is just a click away, right? So if we read Nuclear Donuts in black and white this week, there won't be anybody with ischemia. If we read them in color settings, then, or change the standard deviation setting to 1.5 SDs on our nuclear workstation instead of 3.5 SDs, then everybody will have ischemia, and we'll send everybody to the cath lab and they'll all be normal. Okay, so this is a window width and level setting, and the most important part of this is that you should use standard window width and level settings. And what I want you to do when you log onto your workstation is to set your presets using my standard presets this week. So we're speaking the same language. And that means change your default CTA1, change your default to the default that you get when you click this MIP button, which is 700 and 350. So 700 and 350 is my default for the coronaries, and for the thoracic housekeeping, my default is 800 and 250. So you guys should use these same ones. They're listed on the algorithm sheet as well, and they're incorporated into these workflow files, which I'm giving you to download, okay? Now, when you log on to these servers, it may not be preset that way when you click on these two presets, but it will be when you click on these two, okay? So that's window width and level setting. Other buttons on the screen you need. Any questions about window width and level before we move on? Okay, you got it, good. Other buttons you're gonna need. You need to be able to move around the workstation. So these buttons here, A stands for anterior, P for posterior, it will jump to posterior, F for feet coming out of the screen, L for straight LAO, R for straight RAO. And if you look down here, you can actually see the camera angles with your left eye. RAO 90, cranial 0. If you click A, LAO 0, cranial 0. Okay? So for the cardiologist, your camera angles are listed here. you don't really need to adjust. If you click on that, you can actually enter the exact camera angle, but that's being way too anal. The easiest thing is just to click these letters and they will jump around the various angles, or you can just move across the screen. Left click and move across the screen will also just rotate the heart and thorax into whatever view you want. Okay, so these are the movement of the camera angles. How do you know where you are in space? Well, you just look right here and you'll see this A for anterior, H, F, R, and L. So if I move this like this, you see that F moving across. And up here at the top of the screen, you see H for head, feet, left and right. So that's how you know where you are in space. And the exact camera angle is listed here in case you need it if you're thinking like a catheterizer in the cath lab. All right. So these are buttons you need to move. Now, the other thing you can do is just hit the letter on the keyboard. So if you just hit P on the keyboard, I'm going to hit P on the keyboard, it'll jump to posterior. If I hit L on the keyboard, it'll jump to L. If I hit R on the keyboard, it'll take me to straight REO. And if you hit A, it'll take you back to AP. Okay, so you can either hit them here on the software, or you can, with your right hand on the mouse, or you can use your left hand on the keyboard and just click the letter on the keyboard. Okay. Now, other buttons you may need. This slab button. Sometimes I will start to cut in through the data set and it will lock. It will be stuck and I won't be able to cut through the data. And that's because I've noticed there's a bug in the software. I have to click this slab button twice and then it will let me cut through. That might come up. It's a bug that's been in the software for 15 years and they still haven't changed that yet. I just want to show you the macro, three more buttons here. I want to show you some macros and then these last three vessel viewing algorithms. So the viewing, these up here are called workflows. These buttons are really what we should call them are macros. They are basically a preset that incorporates other buttons. Okay, so when I click this housekeeping window, when I double click this, it just saves me from clicking other buttons by incorporating a change in the window width and level setting. So it changes the window width and level setting to a particular preset. It also hits A on the keyboard for me. And if that's a repetitive task for you, then you just create this preset so that it saves you from a few clicks, okay? If I click this MIP, what that does, it has incorporated 3 buttons in it, like a macro. So it changes the window with the level setting, saving you from having to click this button, CTA2. It also adjusts the camera angle to a steep eleocranial view, and it changes the window width and level setting and gives you an eleocranial view. That's pretty much it, all in one button, okay? So that just saves you from having to click a bunch of repetitive tasks. So there's nothing magical about these that I'm giving you as workflow files. I never used to actually give them to people because they're so easy to make. It takes 2 seconds, but over the years, so many people have emailed me and said, hey man, can you just email me your workflow, your presets? And so many people did that I went ahead and loaded it on that OneDrive for you guys to have in case you sit down at a Terra Recon workstation, okay? The last 3 buttons and on the screen, and then we'll talk about the mouse. The last 3 buttons are right here that you need, and everything else you're not going to need on here. There's some buttons that might be nifty, but this is all you need to learn to read. 3D, MIP, and MPR, okay? these are viewing algorithms. They take the same data and apply complex computation. Okay, the nominal data, the source data is MPR. That's the basics. So when I click MPR, there's nothing more granular or source data than the MPR. That's the basic CT scan. And you know it because when you click on it and you move your mouse around anywhere up in the right, it will tell you what that density is that's calculated at the tip of that mouse. Okay, so that's the source data. But these two are not the source data. They take the source data, the MPR, and they do some complex computations to it. So MIP stands for maximum intensity projection. When I click that, up here, the Hounsfield unit is not listed. What is listed is a slab thickness. And if you right click on it, it'll tell you how many slabs are being incorporated into what's viewed. And I can make that slab thickness using the mouse anything I want. Here's a slab of 99. What you're looking at here is where all the contrast went in a maximum intensity projection. That's what MIP stands for, okay, maximum intensity projection. And when I click 3D, that stands for 3D VR or 3D volume rendering. That's the most complicated of all. When I click that, it applies color. And one of the lessons we're going to learn this week is never trust color, okay? When the computer starts to calculate and apply color, it, while intuitive, because you think you're looking at the heart, you're not. You're looking at a complex computer simulacra of the heart, okay? So we don't trust color. We use 3D simply to move around in space. We use it for great PowerPoint presentations. We use it to find our way in congenital heart disease so we don't miss macro diagnosis, like is there an aorta, is there a pulmonary artery, but we don't use it to make diagnoses. And tomorrow I'm going to pimp you guys, and I'm deliberately set a few traps for you guys to fall into, and you're going to use color and you're going to miss the diagnosis, and then I get to yell at you and say, listen, never trust color. We make all our diagnoses in black and white using MIPS and MPR. Now let's dive, well, that's actually it. That's it for all the buttons you need. All right, so let me review on this 4-dimensional workstation screen, and then I'll ask for questions. You use this distance tool, and if you click this little menu, you can use this polygon tool. Otherwise, I don't use any of those stuff. Use patient list, and back to viewer. You can change window width and level presets here, okay, but they're incorporated into these macro files, so you don't have to if you use these 2 macro files. We rotate around the thorax by clicking these letters here or on the keyboard. And we use these buttons, 3D, MIP, and MPR. And when we want to move through time, we use over on the far left these cine buttons and phase buttons to move through the phases of the cycle. And that's it for the buttonology on the screen. Let's talk about now what the 3D, the MIP, and the MPR actually mean. And then I still have to teach you the mouse moves, but for the mouse moves, I have put them on the file right here at the top of the vessel walking algorithm. Everything in blue on this worksheet is something you do with your hand on a mouse, okay? Everything in blue is something you do with your hand on a mouse. Everything in green is my voice telling you what to think next or do next. Everything in red is something that you speak into a microphone when you are dictating, okay? I went through this and I went through every cognitive granular step so that it's all labeled and color coded. Then in broad strokes, step 1 is assess the study quality, selection, preparation, and we're going to go through this here in a minute, but we're going to do all of that in about 90 seconds in clinical practice. Step 2 is to assess the coronaries. And if you're a cardiologist, you don't really think in segments. If you're a radiologist, you tend to think in segments. That's okay. I just put that on here for you to be able to check off a box if you need to. Then you dictate the coronaries. If there's any intermediate lesions, then we're going to send it for an FFR CT if that's available. It's pretty expensive. It's still running like $1,500 roughly. I think it's down to $700. So we're going to touch on FFR CT later tonight. And then step 3 is where you do your thoracic housekeeping. And make no mistake, guys, all my reviews of mistakes made are here. I am not worried about cardiologists missing coronaries because you're not going to, or if it's an intermediate lesion and you're not sure, you're going to cath the guy already, okay? You all have a license to cath or to send for cath. So if there's a stenosis, you're not sure what's going on with it, 50%, I have complete confidence you guys are going to work it up. You're going to either get another test, a stress test, or you're going to order an FFR CT, or you're going to take them to the lab and do an old-fashioned, high-quality FFR, invasive FFR. And you're justified because cardiac CT is not the gold standard for the coronaries, okay? There is a perfectly famous and good gold standard, which is the cath. But for the aorta and for the pulmonary arteries, this is the gold standard. The gold standard for pathology there is a gated CT. And you don't get to go to the cath lab. You don't get to order a test. So you have to make your call based on CT. That's why we're going to spend a lot of time on that. And in my reviews, this is where people make mistakes. It's in the thorax. And I know why it happens, because we conceive of ourselves as cardiologists, and we do a great job with the coronaries. And then when we get to the rest of it, we don't conceive of ourselves as thoracic specialists, but we should, because our tort system thinks of us as thoracic specialists. When you go to court, you don't get to say, I'm not an aortic doctor, or I'm not responsible for pulmonary emboli, because the trial attorney will stand up and say, you're an internal medicine trained and imager, you are responsible. And there is no defense of saying, I'm not responsible for that, okay? And some institutions have in their report a little paragraph that says, I didn't look at the aorta, so I'm not responsible for it. If you want, if there's any question of aortic findings, please order another scan for that reason. And that's ridiculous, okay? There's no way that's going to hold up in a court of law, okay? So you can put whatever paragraph you want into your reports that might obviate you of some potential liability. It's not going to fly. So some places do that, and that's ridiculous. It's not going to happen. So here's where we're going to spend a lot of time. Step 4 is to review the extracardiac thoracic findings. I got a tip for you. Find a radiologist, shake hands with them, and tell them to do this for you, okay? And make sure the hospital pays them for this, because there is a reason that radiology is 5 years long, okay? You're not going to be able to do as good a job looking at the bony thorax, looking for lymphadenopathy, looking for upper abdominal problems like a radiologist. So Chris Maroulis, who was just on, is my co-founder of Innovation Health Services. We've worked together, cardiology and radiology, for a decade. So in my institution, our radiologists read this portion of the report, and they do a great job, okay? They do a great job. And the hospital pays them a little bit of money for it, for each one. And you should fight for that, because it's a huge liability for us. And then step 5 is to generate the report and communicate. And that's where, this is what our IHS cardiac CT reports come looking like. This is where you dictate the coronaries, something about the EF, if we got all the systolic phases, comment specifically on the aorta, the pulmonary arteries, the systemic thoracic veins, the pericardium. We used to do a calcium score with every scan. We don't do that anymore, not for many, many years, but if you do a calcium score, it's there. And then the incidental non-cardiac findings is added into our reports by the radiologist. And then if you're a cardiologist, if you're comfortable, and you should be comfortable, making a recommendation. If it's non-obstructive disease, then recommend medical therapy. If you have a nurse that's working with you closely and you're reading lots of scans, and I have read 52 in a single day is my limit, then I just circled this because the reports might take 2 or 3 days to come out. So the nurse would call the patient or calls the patient and says, hey, yours is normal, you've got an A. And she basically reads this script to the patient. And I put that on here and then archive for quality assurance. So that's the 5-step algorithm. We're going to dive into that in a second. But the moves on the mouse, when we start going into those in a few minutes, those are labeled here in blue, okay? And there's 7 of those that I've got to show you. Before I do that, let's talk about what these viewing algorithms mean and do when you click them, okay? When you click that MIP button, the computer goes through every row here and it finds the brightest cube and it pushes only that brightest cube to the image. So if you think about it, that is inherently an angiographic projection. When you're in the cath lab and you inject contrast, the image intensifier, the II, is only bringing forward to the TV screen the brightest. It's only bringing the contrast forward, and it's bearing everything else. This week in this course, we're going to tell each other the truth, okay? And one of the truths amongst cardiologists that we fail to tell is that fluoroscopy is blind, okay? How did you guys learn how to cath somebody? If it was like me, somebody handed you an 18-gauge Cook needle and they said, go stick this in this guy's groin and start putting catheters up there. And that's the most ridiculous way to learn because you don't have a 3-dimensional view of where your catheter is going. You don't have it on the screen, nor do you have it in your mind. So you end up putting your catheter, your first 6 months in the cath lab, you start putting it in all kinds of crazy places. You put it up this left subclavian or into the left carotid, and how do you know that you're there? You don't know, except your attending elbows you in the side of your lead and says, hey man, you just stuck it in the left subclavian, pull out. And I remember looking over and being like, I did? I don't remember that. You know, how do you know? How do you know is the curvature of the catheter. So in the cath lab, you are staring at a maximum intensity projection. A fluoroscopy is a maximum intensity projection. A chest x-ray is a maximum intensity projection. It just brings forward to your eye the brightest and buries the rest. So when you click on the MIP button, what it's doing is it's doing something very similar. It's bringing forward the brightest voxels and burying the rest. So this is how I look at PEs. I read my own gated PE protocol studies. So here's a PE study, and you can read them coronally. In 2020, you don't have to read them axially. As long as your slice thickness is 0.6 millimeters, you're as accurate whether you read a thin slice CT, whether you read it coronally like this or whether you read it axially, it's still the same. 20 years ago, it was not the same. But these days, it's the same. So you can read a PE study this way. So this is what my own, if I round on my own patient and I think they need a PE study, then this is what I do. And you can see it's much more intuitive to read a PE this way than it is another way. So when you click that MIP button, that's what it's doing. It's going through every cube and it's bringing forward only the brightest. Now there's a way to adjust the slabs. So if I click a slab thickness of 5, it's going through 5 boxes, or 5 millimeters of boxes, and pulling out the brightest cube and bringing it forward. Pulling out the brightest cube wherever it is in that slab and bringing it forward. So it's inherently an angiographic technique, okay? The 3D VRT is the most complicated. What it does is it assigns every cube a value of color such that the lower density voxels are more translucent and the higher density voxels are more opaque. That's pretty complicated and it's non-intuitive. And then to make matters even more complicated, it calculates a theoretical light source and then shines that mathematically on the heart. So look at this heart. Tell me, where is the light shining from? From what angle of the camera? REO, LAO? What would you guess?
LAO.
No, actually REO. So see, this is the right ventricle, and there's a light shining that is making the right ventricle bright and casting the left ventricle in shadow. So it's coming, so there's a light in the REO cranial shining on the right ventricle, and it's casting this in shadow. If I made this, if it was an LAO light source, it would be over here, and the left ventricle would be bright, and the RV would be cast in shadow. So it's complicated, and you can move the theoretical light source if you get into all the settings. The bottom line is, don't trust color. We only use color to move in space by clicking that 3D button here, back and forth. Find the right camera angle, and then you switch to MIPs and MPRs to make the diagnosis. So you make your diagnosis in black and white. Let me illustrate the point and drill it home, because you guys are not going to believe me, and you're going to make some mistakes, and I can't let those mistakes be dangerous ones. All of you read those 2 papers I sent you? Yeah? I don't believe you. I think some of you just kind of said, I'll get to it, and then you ran out of time last night. So tonight, read those papers if you haven't done it, fellows. I'm sure it's got to be a fellow. There's got to be one fellow in here that didn't read them. If you read them, then let me pimp you. I'll start calling out names here, and we'll figure it out. We'll figure out really quick who didn't do their homework. Here is the left sinus of Valsalva. The left sinus of Valsalva gives rise to the left main and the LAD and the circ. This is the pulmonary artery. This is actually the sinuses of the pulmonic valve. And this is the LA. So this is anterior. This is posterior. This is the left sinus of Valsalva. So what camera angle would you guess this is? LAO? Caudal or cranial?
Cranial.
Cranial, that's exactly right. So this is an LAO cranial view. If you said spider shot or LAO caudal, that's not crazy. That's the exact inverse of the LAO cranial shot, all right? This is our home position in cardiac CT in vessel walking. So this is the left main bifurcating into the LAD and circumflex. And here we see a vessel coming off the LAD. What vessel is that? First vessel off the LAD?
This is the first diag.
Diag.
Okay, so that's D1. There's D2.
OM1.
OM2. This little wisp guy here is OM1. Okay? What's this vessel going backwards?
SA.
Cool.
Yeah, SA. All right. Some guys read the paper. I'm glad. All right. So sinus nodal branch going posteriorly. Most of the time, the sinus nodal branch takes off from the RCA 80% of the time, but 20% of the time, it'll take off from the circ, go posterior between the aortic root and the LA, go off to the SVC RA junction. Now, what's this vessel?
Anterior interventricular vein.
Yes. Anterior interventricular vein, okay? It courses with the anterior interventricular artery, which is the LAD. Now the AIV, as it comes across here, it will change direction 90 degrees and enter the left AV groove along the circumflex, and that's where we give it a new name. What do you call it?
Great cardiac vein.
Great cardiac vein. Okay, perfect. And now there, it's going to continue to course in the left AV groove. It's going to pick up and receive the posterior lateral vein, which is your CRT target. And it's going to course into the right atrium at the coronary sinus, but not before it picks up the middle cardiac vein, also known as the posterior interventricular vein, which courses along the PDA. Okay? If you didn't read those papers, that's like Anatomy 101. You got to read those tonight, okay? This plaque is calcified. It's actually a mixed plaque with a fleck of calcium in the opposite wall. You don't see it here on the volume rendering of the same picture. This plaque right here, this soft plaque in the circumflex that gently smooths into the OM2, you don't see that. In fact, you don't see the diacs. You don't see the OMs. The sinus nodal artery is buried. The veins, gone. So how much should you trust volume rendering? You can't. You can't trust volume rendering, okay? So if you're making diagnoses in volume rendering, other than just big ones, macro diagnoses like, is the aorta present? Is there a coarctation? Is there a pulmonary artery? And camera angle, MIRAO, MILAO, this is what you're missing, okay? So I can't allow that. So we use 3D or VRT to click on a button and get into this position, eleocranial, and then you click on MIP and MPR to switch to make the diagnoses. All right, now this forms a triangle. LAD, circ, and the anterior interventricular vein becoming the great cardiac vein. And the question is, the LAD, circumflex, and the anterior interventricular vein form a triangle. See this triangle right here? LAD, circ, and the vein. This triangle has a name, and my cursor is stuck in the middle of the triangle. What's the name of that triangle? The triangle of Brock and Mouchet, B-R-O-C-Q and M-O-U-C-H-E. It's in the paper on coronary veins, but these were the pathologists that first described it. And there was a large series that came out a year and a half ago on the triangle of Brock and Mouchet of cadavers, because people have been snaring the triangle, putting in Watchmen. You may not realize what hangs right over that triangle of Brock and Mouchet is the left atrial appendage, okay? So the floppy dog ear of the appendage lays right over that triangle of Brock and Mouchet. Let me show you where it is on the 3D workstation. If you can find the appendage on a CT scan in an eleocranial view, and if you just cut through it, you will see the left main bifurcation right below it, right here. And that's where the triangle of Brock and Mouchet lives, right underneath the appendage. So it's important because although our electrophysiologists would love to believe that they can pop a Watchman in here in the fluoro lab, what some of them don't realize is how close they are to the circ and LAD, and I've seen the tines of the Watchman snare the circ before, okay? So, and you can't see the coronaries in a fluoroscopy lab. All you see is your Watchman going in and sheath. So I have no doubt that cardiac CT is going to be the first month of cardiology training in the future. Once our academic institutions line up, before you put a catheter in anybody, you're going to learn your volume rendering anatomy so you understand these relationships. Then you can start putting catheters in the heart and start doing interventions once you have a three-dimensional model in your brain of cardiac CT, because this is what you're looking at on fluoroscopy. All right, so the volume rendering is not to be trusted, except for PowerPoint and for moving around in space. MIPs can be trusted. They have a few caveats, and that is they are not the source data. We use them to make us faster. We'll read the coronaries on a MIP, but if we see a lesion, we have to click on the MPR button to look at the individual lesion. So let me show you what I mean. Here's a LAD. Okay. We look on the MIP for any signs of irregularity or plaque by turning it left and right. And if we see any, then we have to switch to an MPR to look at it on the individual level, on the individual cube level, the source level, to look for any plaque. That's the source data. And you'll recognize you're on the source data because you put your cursor anywhere on the screen, and up here, you'll see the actual Hounsfield unit listed. If you're on a MIP, although it's black and white, you won't see the Hounsfield unit listed. You'll see the slab thickness listed up here. Okay, and that's how you know you're on a MIP. Now here is the key step. All right, perk up here. This is so important. The next thing I want to tell you is so critical, and I still get goosebumps every time I point this out to people because I got my family back when I learned this. The Workstation Terra Recon has a target. When I right-click on the screen, it brings up a target. Why is that in the Workstation? Well, what that is it's a panning function, but whatever cube is in the center of that target, that is where the center of all subsequent rotations will be made around, okay? So it essentially locks on whatever you are looking at that moment. So in your mind and in your algorithm, if you're locking on the aorta at that moment, it should be centered in that target. Your LED should be in there. If it's the aorta, then it should be centered in your target. If it's the LA, then you should pan and make it in your target by right-clicking on it. Now this blue line that moves up and down the screen whenever I right-click is interesting because it also follows that why don't I make it my habit to allow the natural grooves of the heart, the interventricular plane and the AV groove plane, to also line up with those blue lines on the Terra Recon like this, okay? This is so critical to vessel walking. The heart has two natural planes, the AV plane and the interventricular plane, and they happen to be perpendicular to it. The LAD courses in the interventricular plane and creates a complete circle of perfusion with the PDA. And you can look at it from this view, LEO 60, or you can look at it from an REO view, but a complete circle of perfusion has to be completed in the interventricular plane. This is Cardiology Fellowship 101, right? And in general, most patients have a wraparound LAD that meets the PDA. Once or twice, you're going to run into a PDA that grows around the apex and a diminutive LAD will come to it. I've seen it once or twice out of the 33,000 scans I've read in 15 years, okay? Now, the RCA forms a circle of perfusion with the circumflex, and that circle of perfusion has to be complete. And in the cath lab, we commonly look for any territories that are missing a circle of perfusion, right? It's one of the signs that you're supposed to look for is there's a general area on the cath that is missing perfusion, and maybe there's a flush occlusion somewhere I'm missing. Now the RCA plane is perpendicular to this, to the interventricular plane. So AV plane and interventricular plane are perpendicular, and look where they meet. They meet at the aortic valve left main, superiorly, and they meet close to the PDA, but not exactly at the PDA, inferiorly. We call that the crux, inferiorly, but the superior crux, okay, is at the sinus valsalva. It's actually at the aortic valve and the left main orifice. That is our home position. So in vessel walking, the first step is to find the aortic valve and understand the left main usually takes off right beside it. So the left main and aortic valve are our home position, and we are continuously putting that into the center of the crosshair on the blue lines. And that's move one for orientation. And then move two is to make the AV grooves east and west along the blue lines and make the LAD north and south along the blue lines. If you do that, something magical happens to cardiologists. What happens is the natural planes of the heart that you already know fall into place, and you will start reading cardiac CT using the competencies that you already have from echo, from cath, from MRI, because you understand the heart in the 4-chamber plane, short axis plane, and 2-chamber plane. And you won't see those planes unless you also make it your step to line up the planes of the heart into the planes of the blue lines. So, for example, if I put the aortic valve in my crosshair, I'm not quite lined up, but if I put it in my crosshair and left click on the bottom of the screen, I can line up the LAD along the blue lines. It doesn't have to be perfect, but in doing so now, if you look at the blue lines, the AV groove is more or less along the horizontal, and the interventricular plane is more or less along the north and south plane. From this position, if I said, okay, now show me a short axis, all you got to do is left click at the bottom of the blue line here. Left click, sorry, at the bottom of the blue line and rotate to the center. Left click at the bottom and rotate to the center. Now you're looking at a short axis. Okay. If I want to show you a 2-chamber, then I'll left click and rotate 90 degrees. And now you're looking at a 2-chamber. Okay. If you want to rotate back to a 4 short axis, you're here. If you want to rotate back to a 4-chamber, we're here. If I want to see the LAD, then I cut plane back to the surface of the heart, and I'm looking at the LAD because I know that the LAD courses on the surface of the heart just above the septum along the blue lines. And that is the cognitive step that I 15 years ago called vessel walking. And the algorithm here is the vessel walking algorithm. And I put these 2 pictures here to remind you that you're taking the CT data set, and first thing is seeking the aortic valve as the center, to put it in the center of the blue line, and then you're seeking to line up the interventricular planes of the heart and the AV plane along those blue lines. And when you do that, all your prior competencies from echo fall into place, and you will read faster and faster and faster. 2 years of applying this technique, my time for a scan went from 37 minutes to scan to the current, which is 7 minutes per scan. Okay, at your stage, it's going to take you 15 minutes, 20 minutes. And in 10 years, 33,000 scans later, I hope you're down to 7 minutes. Okay, so it's this cognitive step that will get you there if you're a cardiologist. If you're a radiologist, maybe not, because you didn't grow up from the beginning reading echo, you grew up reading CT scans in an axial environment. So maybe it doesn't apply to everybody. Some of you already have an algorithm in your brain. If you've been training some in cardiac CT, great. I don't want to disrupt that. If you already have an algorithm, perfect. But just go through the steps and incorporate the parts of my algorithm that maybe you don't have in your algorithm and blend it together. That's why I gave you all of these sheets as PDFs and as Word files, so to make that amalgamation easier for you. The RCA forms a C-shaped structure. The circumflex forms the reverse of that. The mitral valve, remember, lives in the curvature of that C right here. And the tricuspid valve lives in the curvature of the C over here. Remember that, right? So those are where your valve planes are going to see. On this drawing, you don't see that, but on CT, you will see that. And I'm going to show it to you. Same thing on this view. Although we're used to seeing the coronaries this way, in the fluoro lab, you don't see the tricuspid valve in its REO projection, but on CT you do. And the mitral valve as well, you will as well. So CT is a high definition modality. It's going to show you all of that. So the key here is keep the target lined up to the two natural cardiac planes and then walk down the vessels. Walking down the vessels means manipulating it using the mouse moves, which I'm about to show you, so that you are keeping those targets lined up along the crosshairs. And the first step is usually to find where the aortic valve lives and put it in the center of the crosshair. Okay, it takes a little bit more effort this day to do it, but once you do, it opens up the entire thorax to a cardiologist, because you can then look at an echo and then turn your eye right over and look at the four-chamber view on a CT without even blinking an eye. First thing, find the aortic valve. It is your home position. If you can find the aortic valve, put it in your crosshair, okay? Next thing, part 2 is to orient it so that the septum is aimed north and south down the crosshair. How do you do that? You left click and rotate inferiorly. And that will show you that the septum here is not quite lined up along the crosshair. So you use this mouse move I'm about to teach you to rotate across screen and line it up. That is your home position, a four-chamber view of the heart with the aortic valve lined up in the crosshair. Now, if I use the slab button, which I haven't taught you yet, I'm about to show you, to now curl to the surface of the heart. See here we're in the ventricles. If we curl to the surface of the heart, now the coronaries live on the surface of the heart. If I want to show you a short axis, all I have to do is left click on the bottom of the screen and rotate to the center. And now you're looking at a short axis. If I want to show you the mitral, all I have to do is to cut plane in, and there is the mitral valve. That's the anterior leaflet. There's the posterior leaflet. If we want to cine it, we can click this cine button. Now, it's not as good as a 3D TEE, but it's definitely good enough that if there was a Liebman-Sachs endocarditis vegetation on that, you could see it or miss it and be responsible for it. So missed endocarditis by cardiac CT comes up in some of my reviews every now and then. A big Goomba. Mixed myxomas come up every now and then. You guys I have seen people that went to court because they said no coronary disease, but there was a big myxoma, they didn't even look. One of my own former partners missed massive hypertrophic cardiomyopathy, and she was a level 3 trained, person, just didn't cut into the ventricle. So that's one of the things we're learning today is how to orient it. Okay, so that's vessel walking. That's the Buttonology on the screen, and it's going to take a little bit of practice, and I will show it again and again. These are moves on the mouse, okay? And that's how I've been moving around the thorax. So let's go through them one by one. First one is to recenter the matrix. That's right click, hold, and pan. So on the computer, all I'm doing is right clicking and holding the right click down on the mouse. So now if I move the mouse left and right, up and down, it's simply panning to where I want to be. And one of the rules of vessel walking is you want to pan to whatever part of the algorithm you're looking at. If it's the LAD, then you pan to the LAD. If you are looking at the circumflex in your algorithm, in your mind, then you pan to the circumflex and put it in your crosshair. So whatever part of the heart you are most interested in at this very moment should be in the center of the crosshair. Why? So that whatever subsequent rotations you make to look at it from various angles, it's locked into that central target, okay? And in general, when you start off in a data set, the aortic valve should be in the center, either from the four-chamber view or from the coronal view. You can just hit A on the keyboard here and put it in your center. That's your home position. I really have two home positions. One is click this housekeeping template, put the aortic valve in the crosshair. That's called the AP home position. And the other home position is the same, but from an eleocranial view. And that is my home position. It's very close. It's just the same thing from an eleocranial view because it takes me straight to the triangle of Brocca-Mouchet when I want to go ahead and get the coronaries out of the way first, okay? So in the algorithm, we go ahead and get the coronaries out of the way first, and then we focus our attention on the thoracic housekeeping and the interior of the heart. All right, so that's mouse move number one, is right click. Right click and pan. Now, you'll notice on your mouse, if you right click and you have to right click and hold the mouse down to bring up the blue lines. If you right click and just snap it without holding it, it'll bring up the Windows right click menu. So there's actually two right clicks. There's right click and hold to pan and bring up the blue lines. And then there's right click and let go, and it'll bring up the Windows right click menu. And all of these tools are redundant. They're the same tools that are up here on the workstation. So I don't use it. Next is to rotate. That's easy. You just left click on the screen and rotate left and right. Okay, that's easy. Now, part of vessel walking means you left click and you only try to rotate along the blue lines, left and right. Why is that the case? Well, if you think about it, if you take pains to line up the heart's natural fibrous skeleton along the blue lines as your first step, then all subsequent rotations that you make along the blue lines on the workstation will be in the natural grooves of the heart. So if you are looking at a 4-chamber view, if I want to show the AV groove, I should make a rotation along the blue line, left and right along this blue line here, or north and south, because north and south moves along that target are going to be along the natural grooves of the cardiac fibrous skeleton. Make sense? This is a little bit like when you have an echo probe in your hand and you put it on the PMI and you got to do your own echo. You know how you have to rotate that probe 30 degrees, 90 degrees to get the right views. You're doing the same thing to get standard cardiac plane views, only you're not doing it with your hand on an echo probe. Here you're doing it on the workstation, moving along the blue lines on the Terra Recon, okay? Next move is to cut plane, razor blade. What that involves is you're going to need to hit the right click and hold it down, and then hit a middle click and hold it down. So hopefully you have a wheel on your mouse. So you have to put pressure on both at the same time. You hold down the middle click, or if it's a wheel, you hold the wheel down, and the right click and hold that down too. So that's two down at the same time. When you do that, it will bring up this razor blade. So right click and middle click brings up this icon. That is a razor blade. Now, once those two are held down, if you push the mouse forward or backwards, it will cut in through the heart, or it will scroll through the data set from front to back, okay? So in this way, the entire matrix of CT density cubes that was scanned is accessible to you in the heart, outside the heart, surface of the heart, orientation. So that's cut plane. And remember, there's one little bug in the software, and that sometimes you're trying to cut and it's locked. Like you see the razor blade, but it's locks like this. You have to click this slab button twice and it'll work. I hope they got that bug out in the software. But next one is to zoom in, and that's middle click and scroll up and down. That's pretty easy. All you do is Hold the wheel down, it brings up this magnifying glass. Okay, now you push the mouse forward or backward and you can zoom in. The mistake I see fellows make is they read this small like this and they're staring at the screen when they forget that they can just zoom in and look at the pathology, and it's more likely you're going to make a diagnosis when you're looking at it zoomed up than, you know, as a small structure. Okay, so zoom in to save your eyesight, and my eyesight too. Next one, to rotate the on-screen image, not the matrix. What do I mean? What you do is you left click on the edge of the screen. Here's what I'm getting at. When I say the matrix, I'm referring to this matrix of voxels. So let's say we're reading this LAD and we're looking for any plaque. There's a septal. And I am going to tell you to always keep your LAD lined up north and south along the crosshairs, looking. But at some point, the LAD here bifurcates. This is the true LAD going in the interventricular groove, and a big bifurcating diagonal takes off here. So I want to keep tracking the LAD, but the LAD is not going down the blue line. It's going off into this quadrant. So how do I line it up? Well, what you do is you left click along the edge of the screen and it brings up this little curly Q. And then you simply rotate gently straight across the screen. And now the LAD is lined up north and south. Okay? Now, if you do it the wrong way, which is the left click here, and instead of rotating straight across, you left click diagonally into the screen. I went from here to here. Look where you end up, inside the ventricle. And that's because you didn't just rotate it on the surface, you rotated the entire data set into the ventricle, okay? And then you'll get lost. So you have to be very discreet with your mouse movement to move. When you want to line up something, to left click on the edge of the screen is to rotate straight across. Without making a move into the screen, you have to move straight across. Okay, and what that does is it simply takes, look at me for a second, it takes the on-screen image and it just moves it 90 degrees on the screen without actually rotating into the plane of the thorax, okay, where you're more likely to get lost. So that's what that move is. The next one is to thicken the MIP slab. Now, that one is easy. When you're on a MIP or a volume rendered program, either 3D or MIP, one of these two buttons, up here it will list the slab. If you're on a MIP, rather than just right click on this and go to the MIP slab, those only go out to 12 millimeters. If you do what's listed here and click Control with your left hand on the keyboard, hold the wheel in and move the mouse left or right, then you can make the MIP slab whatever you want. So I'm going to hit Control, I'm going to hold the wheel down, and it brings up an arrow that's pointing straight up. I don't know why. But now if I move the mouse left or right, watch the MIP slab will go to 27. It'll go to 46. It'll go to 90. I can make it whatever I want, and I can also make it thinner. The advantage of making the MIP slab, say, 23, is that you can generally see the RCA, for example, in its entirety at a large MIP slab. So this is a MIP slab of 30. It took me adjusting the MIP slab to 30 to be able to see the RCA in its entirety. Now, the unfortunate part is you cannot read the RCA at a MIP slab of 30. You can't do it. You won't be accurate. You have to read coronaries at the MIP slab that they were born, which is about 5. So you have to read the coronary at a MIP slab of 5, but unfortunately, if it's a tortuous vessel, it's not going to come in all at 5. So we read coronaries at 5 millimeter MIP slabs, switching to MPR to look at the individual lesions when we find them. So the MIP can be adjusted either by clicking on it up here or by simply hitting control, getting this arrow pointing up by hitting the click in the middle of the wheel, and then pushing the mouse back and forth to raise or lower the MIP slab. So usually what I do when I get to the RCA in the algorithm, which we're going to do after lunch, is I usually make the MIP slab transiently 30, just so I can see just for a second if the RCA is indeed not totaled and is it dominant. And then I make it a 5 again and actually assess it segment by segment by vessel walk. The last move on the mouse is to superimpose the MPR window. I call that the gangster window. Okay, so you click on off G. It's a new feature. I didn't historically use it. It's really not that helpful, but I put it on here. Let me show you what it does. When you're looking at an LAD or any vessel, coronary, here's what I've done for 15 years is I look at the vessel left and right, 90 degrees across. I left click here, I rotate 90 degrees over here to look for any eccentric plaque that might be out of plane. Then I rotate back. I left click here and I rotate 90 degrees this way and I rotate back. I look for any plaque. I don't see any. Let's say and I'll move on. If I do see some plaque there, then I will, what I've historically done is I've left clicked and I rotated it into a short axis IVUS view, what used to be called virtual IVUS view. And then I click the MPR button here to look at it one slice at a time to look and see what that plaque might look like. Okay. Now, that's the old school way of doing it. I'm an OG. Okay. But the new Gs, they do this gangster window thing. So if I click G on the keyboard, it brings up a window right here. That's the gangster window. And it's basically an MPR superimposed on the MIP. And this green line here is showing you the plane in that green area. So if there's an individual lesion, you hit G for gangster window, it brings it up. And now you can grab this green line and move up and down the vessel. Okay, and you can do the same thing I was doing, get those virtual IVUS views, short axis views of the vessel by moving up and down. And you can change the angulation a little bit by grabbing this bar if you want to. Okay. All it does is it allows you to see both at the same time. And then to get rid of it, you hit G for gangster again, and now it's gone. So that's the new gangster way to do it. And the old way is that I've always done. That's I think is faster, but is to just rotate along the vessel and look in the short axis views. Now, 15 years ago, before the FAME trials, I used to do this all the time. Look in the virtual IVUS views and look at all these lesions that way. That was back when we really believed that anatomy predicted physiology. These days, we're smarter than that, and we know that even a 40% lesion can be flow limiting, and we know there's plenty of 75% lesions that are not flow limiting. So once the FAME trials came out and basically settled the issue, the invasive FAME trials, which were very well done trials, now we know, look, when you have an intermediate stenosis by an anatomic test, whether it's a cath or a CT, you should go after physiology in order to determine whether the stented or not. And ischemia just came out and showed us the same sort of lesson that we keep learning repeatedly and repeatedly in cardiology. So these days, I don't use that gangster window much, and I don't use that virtual IVUS much. If I have an intermediate stenosis, rather than convert it to a short axis view and wonder whether this 60, 70% stenosis is flow limiting, I realized I'm not going to figure it out because I'm looking at an anatomic test. So that's when we need to do another test. So we're either going to order an FFR CT, or if it's a good story, we're just going to go to the lab and do a old-fashioned invasive FFR, or maybe we'll do a nuke to see if he has any high-risk findings, and if he doesn't, treat him medically until it's time. So that's why I don't use that OG much anymore, that virtual IVUS view. Look, learning cardiac CT is a little bit like drinking water out of fire hose. I know it's complicated. It's a high definitional technique, and we wish it was as easy as reading nuclear donuts. It's not. It takes a lot. So we know that, and so important things I'm going to repeat over and over again so they soak in. And so you hear it in your brain as you start to read these cases on your own.